welcome to our presentation on the opioid analgesics. So this presentation was adapted from the lecture of Dr. Kumari Anchana of the Bihar Animal Sciences University from India. In general are considered to be analgesics. So when we say analgesics, these are the drugs that significantly relieve pain by acting in the CNS or in the peripheral mechanisms without affecting consciousness. So we usually refer to opioids as opiates, but they are actually different. When we say opiates, these refer to natural opioids such as heroin, morphine, and codeine. When we say opioids, these refer to all natural, semi-synthetic, and synthetic opioids. The analgesics are divided into two main groups. The first group are the opioid analgesics. So these are also termed as narcotic or morphine-like analgesics. The other group are the non-opioid analgesics. So these are also known as non-narcotic or aspirin-like analgesics. So just a short review of the word narcotic. So the narcotic was initially used to denote any drug capable of producing sleep or narcosis. It was generally applied to the opiates. However, the term is now used to denote drugs of abuse that are controlled by the government agencies. So the term opioid now is preferred instead of narcotic when describing the opioid analgesics. So what are the differences between narcotic analgesics, which are also known as the opioids, and the non-narcotic analgesics? So for the non-narcotic analgesics, of course, they can induce CNS depression or narcosis, whereas for the non-narcotic, they have no significant CNS depression. In terms of the application of these analgesics, so the narcotic analgesics are usually indicated for deep-seated or visceral pain, whereas non-narcotic analgesics are usually indicated for mild, moderate, acute, and chronic pain. For the narcotic analgesics, the of course, the addiction is considered to be a concern for the narcotic analgesics for the opioids, whereas for the non-narcotic analgesics, addiction is considered to be absent. Pain or analgesia is actually a protective mechanism of the body, and it is produced by damage of tissue and subsequent liberation of various chemicals that are also known as the endogenous mediators of pain. So this includes, for example, the bradykinin, serotonin, histamine, prostaglandins, acetylcholine, and substance P. So these pain mediators will interact with the pain receptors, also known as nociceptors, that are present in the skin or other tissues. So we can also classify pain based on their speed at which it travels in certain nerve fibers. These are the fast pain and the slow pain. There are two types of pain in the body. We have the fast and the slow pain. So how do we differentiate the two? So the fast pain usually occurs in the body surface, and this can be induced by an acute stimuli such as a needle prick. So from the name itself, this is felt within 0.1 second after the stimuli. This can be induced by stimuli such as the knife cut, the needle poke, or burns. This is not felt within most deeper tissues. For the slow pain, the pain is usually involves the body surface as well as the deeper tissues, and that is induced by the damage to the tissues. And this is felt after 1 second or more, and this includes throbbing or aching pain. This is usually associated with tissue destruction. So when the tissue undergo tissue destruction, so they can release some endogenous pain mediators, including this bradykinin, serotonin, histamine, and others. In terms of the nerve fibers that are involved for the transmission of the fast pain and slow pain, for the fast pain, these are transmitted from peripheral nerves to spinal cord by myelinated fibers. So they are also called as small diameter myelinated fibers, myelinated A fibers. For the slow pain, the pain signals are transmitted by large diameter non-myelinated C fibers. Pain can be classified according to the basis of the duration. So pain can either be acute or chronic. So when we say acute, this is usually associated with tissue damage and increased autonomic nervous activity, and the pain will disappear with healing of the injured tissue. When we say chronic pain, that the pain extends beyond the probable period of healing, so that is about 3 or 6 months, no beyond inception. The patient has a depressed mood, depressed health, as well as functional capability. On the basis of the pathophysiology, so the pain can be classified as either nociceptive or neuropathic. When we say nociceptive, the pain arises from the activation of the sensory receptors, nociceptors. Example of this are the musculoskeletal disorders. We also have the neuropathic pain. It arises from the damage of the peripheral or the central nervous system tissue. Diagram represents the pain pathway and the analgesia effector site. So we have here our physiologic pain. The physiologic pain is detected and interpreted by a nociceptive sensory system. So in this case, we have the nociceptors. It responds to pain through the process of transduction, transmission, modulation, and perception. So we also have at the different sites of at the different steps of the pain pathway, we have here our modulators and therapeutic modulators or our analgesic drugs. So at the level of the transduction, we have our opioids, antihistamines, local anti-anesthetics, as well as NSAIDs that can interrupt the pain pathway. At the level of the transmission, so we have here the local anesthetics and the opioids. We also have at the level of the modulation, particularly at the spinal cord, we have the opioids, alpha-2 agonist, and NMDA receptor antagonists will be able to act in order to interrupt the pain pathway. The level of the perception in the brain, we have the opioids, alpha-2 agonists, and the general anesthetics. Opioids are a class of drugs that derive from or mimic natural substances found in the opium poppy plant. When we say opium, that is an air-dried milky exudate obtained from the poppy plant Papaver somniferum and ripe seed capsules. There are only two opiates which have clinical value. This includes the morphine and codeine. It contains 32 alkaloids that are divided into two groups. The clinically significant one is the phenantine group. So under the phenantine group, we have the morphine and codeine. For its effects on the CNS, so it can cause depression or excitation, analgesia, and of course, it can induce addiction. Morphine is a strong opiate that is found naturally in opium, a dark brown resin in poppies. It is mainly used as a pain medication in human and veterinary medicine. It is also commonly used recreationally or to make other illicit opioids. In the year 1803, Friedrich Wilhelm Serturner, a German pharmacist, isolated morphine and named it after the Greek god of dreams, Morpheus. Opioids are the core pharmacological treatment for acute pain. Now, they act via receptors on the cell membranes, and these receptors are G protein coupled receptors. So opioids are divided into two types. We have the exogenous and the endogenous. So some endogenous opioids that bind to the receptors are enkephalines, endomorphines, and dynorphines. Examples of exogenous opioids are morphine, heroin, and fentanyl. They are substances that are introduced into the body and bind to the same receptors as the endogenous opioids. So to date, there are 5 types of opioid receptors that have been discovered. We have the mu receptor. We also have the kappa receptor, the delta receptor. We also have the nociception receptor that is not shown here, and the zeta receptor. So only 4 of these are shown in this diagram. When mu receptors will be activated, again, when, for example, an endogenous opioid or an exogenous opioid will bind to the mu receptor, what it does is it will induce analgesia, it will induce indifference, cough suppression, respiratory depression, cardiovascular depression, physical dependence, and hypothermia. When the delta receptors will be activated, so the physiological roles of this receptor include analgesia and indifference. For the kappa receptor, we have analgesia, sedation, and ataxia. We also have the zeta receptor, so this includes euphoria, dysphoria, hallucinations, excitement, and probably analgesia. Table shows the three major opioid receptors, their clinical effects, and their locations. So again, in the mu receptor, when a mu receptor will be occupied by an agonist that can be endogenous or exogenous, so it can induce a clinical effects such as analgesia, changes in the smooth muscle tone, sedation, mood alteration, and nausea or vomiting. When the delta receptors will be activated, so it will induce this decrease in the colonic transit time. And for the kappa, it can induce central analgesia, decreases in the colonic transit time, and the visceral nociception antagonist. For their location, so these are the locations of the mu, the delta, and the kappa receptors. Way of the opioids. So the analgesic effect of the opioids is through their action on the opioid receptors. So again, they are GPCRs or G protein coupled receptors. So the opioid analgesics will block the nociception neuronal pathway. So the of course the opioid receptors are found now in the spinal cord and the brain. So they will actually block the pain pathways, including um, the modulation as well as the perception. Hence, now when the opioids will be able to act on the opioid receptors, the pain sensation will not be felt. Pharmacological effects of opioids, particularly morphine. So in the CNS, it can cause depression or excitement depending on the species. So for man, monkey, and dogs, it can cause depression. And for cats, cattle, sheep, goat, and horse, it can cause CNS excitement. Of course, it has an analgesic effect. The effect is due to central and peripheral actions, blocking the nociception transmission. It also relieves acute or chronic deep-seated pain without impairing the motor activity. Of the opioids, particularly morphine on the GIT, so it can cause severe constipation. It causes emptying of the GIT through vomiting or defecation. It can also cause constriction of the sphincter, interfering with peristalsis. No? And it suppresses the defecation reflex and causes constriction of the anal sphincter, causing severe constipation. And respiration, so it can, of course, induce respiratory depression. So higher doses can cause direct depression of the medullary respiratory center. And associated with this is bronchoconstriction. This is due to the histamine released by morphine. Cardiovascular system, so it has no significant effect at analgesic doses, but it can cause hypotension due to the release of histamine. At higher doses, it can cause a fall in the blood pressure and bradycardia due to the depression of the vasomotor center. On the cough center, so certain opioids are potent antitussive, so they are considered to be cough suppressant by depression of the cough center in the brain. For the emetic center, it can cause nausea and vomiting through the stimulation of the chemoreceptor trigger zone at analgesic doses. The pupil, it can cause marked dilatation or mydriasis in horses, monkey, sheep, and cattle. For dogs, rats, and rabbit, it can cause the pinpoint pupil or meiosis. For the body temperature, it can cause hypothermia in man, monkey, dog, rabbits. But in other animals, it can cause hyperthermia. So when we say hyperthermia, this is applied for cats. For example, hydromorphone and morphine, it can induce hyperthermia post-operatively in cats. Hyperthermia is due to the release of serotonin in the hypothalamus. For the kidney, so in dogs, it can cause initially it can cause urination, particularly for morphine, and later oliguria or anuria. That is due to the release of the antidiuretic hormone. It can also increase the tone of the urinary bladder and constriction of the bladder sphincter. These are the opioid receptor agonist and the antagonist. For the opioid agonist, we have morphine, codeine, hydromorphone, oxymorphone, meperidine, and methadone. Opioid antagonists include naloxone, buprenorphine, naltrexone, and nalmefene. For the partial opioid agonist, this includes buprenorphine and tramadol. And for the mixed, meaning opioid agonist and antagonist, this includes nalmefene, pentazocine, butorphanol, and nalorphine. Metabolism, so morphine is metabolized through conjugation in the liver. These are the clinical uses of morphine. So it can be used, of course, as an analgesic. It is a pre-anesthetic medication. It is also used to relieve post-operative pain and to treat severe diarrhea. For the toxic signs of morphine, so the toxic signs include CNS excitation and constipation. So the long-term use of morphine in dogs can cause addiction and physiological dependence. So other opioids include diamorphine or heroin. So this is about 5 times as potent as morphine and as an analgesic, narcotic, and respiratory depressant. We also have methadone. So methadone is a synthetic compound approximately equipotent with morphine as an analgesic. It is a powerful antitussive agent and used for horses and dogs for cough suppression. The agonist is the betadine or meperidine. It is about 1/10 as active as morphine as an analgesic. It is less likely than morphine to produce narcosis, vasodepression, emesis, and depression of the medullary cuff and respiratory center. Thus, it is more suitable for use in dogs and pregnant animals than morphine. We also have apomorphine. So apomorphine is less potent than morphine as an analgesic and narcotic, but the central stimulant effects are increased. It is particularly potent as a centrally acting emetic, acting as a stimulant on the CTZ, a chemoreceptor trigger zone of the medulla. It has also been used as as an emetic in the dog in cases of poisoning. Another is dextromethorphan. So dextromethorphan lacks most of the properties of morphine, including analgesic, addictive, narcotic, and spasmogenic actions. It does, however, depresses the cough center in the medulla and is used clinically as an antitussive or cough suppressant in dogs when control of the dry productive cough is required. We also have fentanyl. So fentanyl is approximately 50 to 100 times more potent than morphine as an analgesic. So the main use of fentanyl is neuroleptalgia. So again, when we say neuroleptalgia, that is a combination of a tranquilizer and um, of course an analgesic agent to producing potent sedation in animals. Slide shows the application of fentanyl patch on the dog. So again, we have here the drug and it is usually applied on the shaved skin for the dog. So the fentanyl patches is a patch that is placed directly on the skin and it has slow constant release of the drug fentanyl. And fentanyl is again a potent narcotic absorbed by the bloodstream of the patient. The patch is very beneficial. So among the applications of fentanyl patch is for surgery. We also have for procedures such as traumatic chronic pain, such as for cancer patients, and also for those dogs with systemic illness, such as pancreatitis. And it is also used with multimodal approach. Um, for the application, so this patch can be applied 24 hours before the scheduled procedure. So for other types of opioids, we have the etherphine. So the etherphine causes neuroleptalgia. It is about 1,000 times more potent than morphine, used to immobilize wild animals for trapping. We also have buprenorphine. So buprenorphine is a partial agonist on the mu receptors. They are usually indicated for mild to moderate pain in small animals. For cats, the buccal administration of the injectable liquid is often used to control pain after surgery. So these are the dose of the and the application of the buprenorphine in dogs, cats, and pigs.